we'll start with the first lecture by Dr. Mangala ma'am, who is the current head of the Department of Cornea in Arunhai Hospital, Coimbatore. Thank you, ma'am. Ma'am, I will change the order.
Thank you, Dr. Naveen. Very good afternoon to all of you. And my talk will be on risk factors and clinical features of non-resolving corneal ulcers. So as we all know, the stages of ulcer healing, in any ulcer, the treatment is started, then first thing the ulcer stops worsening, and then there is an inflammation and repair process, and then the tissue remodeling with fibroblast and everything, finally the healing and clarity. This is a routine way of healing of an ulcer. Here we can see few ulcers which we can beautifully, the ulcers have healed with all these processes. And so when do we call an ulcer as a refractory ulcer? Because when there is no healing response to conventional therapy. So the clinical features of them will be, there will be no response to the treatment. And then the patient will not be improving symptomatically, and the defective epithelial defect and the infiltrate may not be decreasing. So there are a certain time frame for different etiologies. Sometimes bugs like rare bugs like Pythium, microsporidiosis, acanthamus, they take a long time to heal. So those ulcers, we should not think that it is not healing. So that time frame of healing each ulcers also we have to keep in mind. And before labeling as a recalcitrant ulcer, the thorough, complete microbiology workup to be done. So what may be the causes for the non-healing ulcers? First thing, that may be a wrong line of therapy. Maybe without a microbiological workup, the therapy would have been started. It would have been like a bacterial ulcer which is treated as fungal or whatever. So the long line of therapy. Then inadequate therapy. Still now we see patients who are using homemade for hourly and nata for 2 times. So we have to be very we have to explain the patient very thoroughly that which drug to be applied hourly and which accordingly we have to. So inadequate therapy will also be leading to non-healing ulcers and non-compliance to treatment. So any ulcer patients should be educated that this is going to be a long process, long journey. The patient has to come for follow-up regularly. They have to use the medications regularly. So all these things should be explained to the patient. Otherwise, it is going to be a non-healing ulcer. And also drug resistance. Even if we get a proper micro organism, but we have to find the sensitivity also. Sometimes we may be using a drug which is not sensitive to that particular organism, so that may lead to non-healing ulcers and drug toxicity. And sometimes certain ulcers like acanthamoeba, pseudomonas, inflammation may also be associated. So that also to be taken into account and treated. Otherwise, these ulcers may be looking like a non-healing ulcer. So last but not least, the deeply situated ulcers also, and ulcers with mixed etiology and other associated risk factors like systemic risk factors also should be kept in mind in treating non-healing corneal ulcers. And the symptoms, as we were discussing before, the patients will not be responding symptomatically. They will be worsening with persistent pain, decrease in vision, light sensitivity, and vision loss also in severe cases. So the clinical features will be non-healing epithelial defect. The underlying infiltrate will be keep on increasing. Ulcer edges will be progressive. Hypopyon will be increasing. Thinning and melting will be there. And even adjacent structures like scleral involvement will be there and associated vitritis. The clinical profile of non-healing ulcers will be like recurrence of infection, indolent ulcers, neurotrophic ulcers, and ulcers larger than 6 mm, deep stromal ulcers, and sometimes impending perforation. So coming to common organisms but non-healing, fungal keratitis, sometimes they will have intact epithelium with typical stromal infiltrates and sometimes only endothelial plaques. They will have a typical clinical features, but they'll be very deep-seated, and the keratic precipitates exudates over the endothelium and over the iris and anterior surface. They denote an actually deeper infiltration of the fungus, and these fungus will have these kind of infiltrates. There will be a poor penetration and accessibility to the therapeutic agents, which may lead to a non-healing ulcer. In the same way, Pseudomonas ulcer, they have a very stormy course. These bugs will contaminate any substances in the earth. They have hyperacute stormy course, and within few days they will increase and they go for melting and perforation. So in this kind of ulcers, we should not wait for healing, and then we have to react immediately. Staphylococcus aureus, this can happen in compromised corneas, and the patient in hospital admission patients, they have a relentless course, but in the same way, if it is a methicillin resistant organisms, usually they don't respond to broad spectrum antibiotic coverage, then they will be non-healing. So accordingly, the antibiotic sensitivity to be done and then treated accordingly. Also, when coming to the rare infections, we have to keep them also in mind, like Pythium, atypical mycobacteria or microsporidia. These ulcers to be taken into account. We need to know the typical features of these ulcers. Like this ulcer may be looking like a fungal ulcer or something, but when we come and see that edges, we can see that cracked mirror or windshield appearance usually happens after any surgery. It has a slowly progressive course, and it's more common after any surgical intervention. Same way, acanthamoeba infection, it can come after a wet mud injury or contact lens, or due to swimming. This can be the main source of infection. Here also the course will be very chronic course in serious onset. And then many times we have seen patients like acanthamoeba or microsporidia nowadays, they come as they have been treated like a viral keratitis with steroids and other medications, and then later they present to us, and then finally we have to do, when we do a microbiological workup, we come to know that it is an acanthamoeba keratitis, and then we have to treat them accordingly. So coming to the risk factors, we need to keep the systemic risk factors also in mind. A very young patient with a fungal keratitis, the healing process will be different from a patient who is more than 60 years with chronic diabetes, along with some collagen vascular disorder. The healing process might differ. So we need to know about the nutrition condition of the patient, anemia, immunocompromised status, alcohol dependence, age, thyroid, and any oral immunosuppressants, diabetes, and collagen vascular disorders. Also, the history is very important here in treating these non-healing ulcer patients. Sometimes the infections with comorbidities, they have to be taken into account because they may alter the immune status, and then definitely they'll be intervening with the healing process. So we have to balance the therapy accordingly. Few cases, examples I've shown here. This is a patient, 55-year-old female. She came to us with a corneal ulcer which was treated for 2 months elsewhere, and she was using these medications. Systemic history, she had hyperlipidemia, thyroid disorder, and also she was taking tablets for joint pain, seronegative arthritis. She was taking sulfasalazine, and we did a micro workup and few gram-negative vesiligro, and other things were done. She was admitted for close observation, and we stopped all medications, and dexamethasone with polymyxin was given for 2 times, and oral doxy was started. She was recovering well. In between, she herself stopped the sulfasalazine drug, oral drug, and then she was healing much better. So here, in this condition, it might be because of the oral sulfasalazine, we don't know. We again send the patient to a rheumatologist workup, but because her other status were normal, they didn't ask her to restart the sulfasalazine. Maybe it can be because of a NSAID-induced drug melt, we don't know. So here this would have been a part, like NSAID-induced drug melt would have been a reason for non-healing. So this is another case. Patient who came with the mild pain and redness for 3 months, treated elsewhere. And here the initial photographs I don't have. She had a systemic history of rheumatoid arthritis on HCQs and prednisolone. Hypothyroidism was there. She is a hypertensive. Hyperlipidemia was there. An asthmatic, diabetic, everything for the patient. And here she had both eyes. She had epithelial defect with mild thinning and peripheral vascularization. And she also had some periocular facial pigmentation with lid margin thickening. So this was the patient's condition when she presented the first photograph, and then we suspected an ocular lichen planus, and then we did a biopsy, and the patient came positive for lichen planus. Then we have to work with the rheumatologist. The patient was referred to them, and then systemic immunosuppressants were started, and then the patient was healing much better. This is another patient with the lichen planus, already a known patient on MMF. And for this patient, he had an superadded bacterial keratitis, which was healing with fortified antibiotics. But then there was vascularization. As we all know, it was a good sign. But unfortunately, this patient, behind the vascularization, there was a melt. So the panus resection was done. Then the patient was healing well. And also his systemic therapy was going on. So here also the autoimmune status and the may be the reason for non-healing ulcer. So we need to keep in mind about ocular comorbidity also. When there is a non-healing ulcer, we need to know if the ocular surface is compromised, we may have a non-healing ulcer. So those things should be taken into account. So here it's a picture of a step pneumo with an advancing edge. So associated with chronic dacryocystitis. Once it was addressed and the surgery was done, the patient was healing much better. The second photograph, we can see a lot of dot infiltrates in the peripheral cornea. And when we avert and see the lid margins and all, we can see a lot of MGD and MGD present. And here, along with the antibiotics, mild steroids were started, and then the patient started healing. So tropic component also to be kept in mind, like diabetic corneas, neurotrophic corneas, or stem cell deficiency patients. Here we have to, because of the damaged basement membrane, the ulcers or epithelial defect may be very slow healing. So these things to be treated properly, then the process will be hastened. So last but not least is mimics of the corneal ulcer. Sometimes it may not be a corneal ulcer at all, but we will be treating as a corneal ulcer. The first one, this photograph is a patient who had a injury, and then the patient was given medicines for 5 days or a week, and then they came to us. And then on proper history taking, we found that they had an injury with a stick. Then I didn't have the AIOS2025 picture. When we did, there was a lamellar tear. So that was a tear with the corneal edema. So when we gave just one suture to that place, and then the patient healed well. And second thing, it can be due to a toxic reaction. In this photograph, we can see a kind of a necrotic infiltrate, but luckily here we can see a small sting in that corneal necrotic area. Because of that sting, it was a toxic reaction to that sting. But many times we may not be able to get this sting or a small hair in the infiltrate. So we need, in here the AIOS2025 will help us. So we have to do an AIOS2025 and find out also the ocular history. So once that is removed, this will come down dramatically along with steroids, judicious use of steroids. And even phacolytic glaucoma sometimes can be mimicking a corneal ulcer, non-healing, and exposure keratitis. It will be looking like a florid infiltrate, but once the reason for the exposure keratitis is taken care of, and with tarsorrhaphy and other things, lubricants, it will be healed. So even a foreign body, this photograph actually, it may look like a pigmented corneal fungal ulcer, but surprisingly this is not that, and this is a small husk which was attached to that cornea. And once the husk was removed and the mild dose of antibiotics was given, and it healed completely. So they may be mimicking a pigmented ulcer, and on top of it we'll be pouring antifungals, and even the drug again it will be deposited over that, and it will be confusing for us. And the same way, chemical, thermal burns, shield ulcer, etc. can be mimicking a infiltrative ulcer, but proper history and examination will give us a clue. So this is one of another case where we can be mistook as a corneal ulcer. The patient typically presents with infiltrative abscess, and when we look for the other features, we can see a perilenticular exudates, vascularization, moderate AC reaction, and this is none other than the lenticular abscess. Here we have to do a lens cataract extraction. Along with the antibiotics, we have to give a mild dose of steroids, which will help us to heal the patient well. So this is a patient who came with the first photograph, who came with a non-healing ulcer treated elsewhere for 2 weeks. Then we gave, he gave a history of injury with an insect. So we started with mild antibiotics and even mild dose of steroids, but he was not at all recovering. And then here we could find out that lens matter also, like as I showed you in the previous slide. So then there was an lenticular abscess. We did a lens cataract extraction, and this is the second picture after the cataract extraction. Still we can see some exudates over the iris and all. After use of steroids, and the patient was healing like this. And this was the center picture, was the final picture. You can see a very good response to the patient. So this patient was initially treated with all antibiotics, antifungals, and everything. So now we have stopped, and with minimal antibiotics and steroids, he was improved dramatically with cataract extraction. So these things also to be kept in mind when we see a non-healing ulcer, like contact lens wearing, previous ocular surgery, trauma, etc. And also the ulcer profile, supraocular infection, antimicrobial resistance, refractive organisms, and any surgeries. Drug-related also to be kept in mind, drug resistance, poor drug penetrations, poor compliance, low dosage, and sometimes chronic anesthetic use and steroid use also may lead to non-healing corneal ulcers. This is one case where the patient was given steroids for, the patient is a known case of NVG. Yeah, only one last slide. And was given lot of medications. So finally we have to stop the medications and do a scraping, and with minimal steroids he improved. So finally we have to assess the response to empirical therapy. If there are multiple drugs, we have to try to withhold with one by one, and then immune and inflammatory other conditions to be taken care of, and titrate the medications and address the associated factors. Finally, if nothing is working out, then we have to go for a therapeutic keratoplasty. So it is a challenging condition with multifactorial etiology. We need to work with other specialists and for the complete healing of the ulcer, and we need very good cooperation from the patient side, because it is going to be a long journey. Thank you.